Hi, my name is Pia Tuominen, and today I'm here with Professor John Reed to record a new episode for our series, Challenging the Medical Model of Mental Health, a call for humane evidence-based services that respect human rights. And it's very nice to be here with you, John, again. And today our topic will be antidepressants.
Lovely to be with you again, Pia.
Yeah, and just to introduce you a bit, you're Professor of Clinical Psychology at the University of East London and the Chair of the International Institute for Psychiatric Drug Withdrawal. And I'm a former psychiatric patient, and I like to use, for example, my podcast to challenge these mainstream views of psychiatry. So it's very nice to be here to do this, exactly this with you. So antidepressants. I was thinking that perhaps we could start by because one of the common things I hear when I talk about these mental health issues on my Finnish Facebook page and everywhere, one of the common things I hear is that these antidepressants work. They just work, and you can't challenge them because it's scientifically researched that they work. So I was wondering if we could start by, could you give us a brief introduction for people who may not know, like what is the clinical this trial process that, let's say, the claim of effectiveness is based on?
Okay, so the basic way to, or the primary way, the gold standard way to evaluate whether any treatment works, of course, is a randomized control trial where you compare the treatment, in this case antidepressants, with a placebo, in this case usually an empty capsule, designed to look and feel and taste like the real thing. So ideally, in a properly designed study, people really can't tell which one they're getting. And overall, when the meta-analyses and the big literature reviews come in, there is actually very little difference between antidepressants and placebo. Overall, there is no difference for mild depression and moderate depression. And then there's a debate about whether there is a small I think it's fair to say there's a small percentage of people who are at the severe end, the very severe end, the top 5%, if you like, of severity of depression, who do get some temporary relief or lift of mood, however you like to put it, from the antidepressants over and above what they get from placebo. So for the vast majority of people, these drugs are no better than placebo, and a lot of people have conceded that. I have to add, Pia, however, that doesn't mean they don't work. I mean, placebo is, just to briefly explain, I know you know, but just for listeners, spatiation of hope and expectation that you're going to get better. And by the time you've A, decided you've got a problem, B, decided you're going to do something about it, C, you've talked to somebody who has listened long enough, maybe not as well as we might have, but they've listened and they've decided they know what's wrong with you and they know what to do and they're doing it and you're doing it, or you put all of that together, plus the need we all have to want to get better, combine all that together. It's a very powerful set of expectations that make us feel better, just because we've done something, and because another human being has cared enough, even if it's only 10-15 minutes, to listen to us and is trying to help us, and that all feels really good. So the fact that it's mostly placebo for most people doesn't mean that people aren't getting some benefit from it.
Yeah, at least some people. Yeah.
Okay.
Yeah.
And if there weren't all the adverse effects, which I'm sure we'll come on to, I wouldn't have any problem with it. Well, if it works, it works. And a lot of what we psychologists do is our placebo effects, or general effects, as some people like to call them, the creation of expectation and hope. So there's nothing wrong with that, but there's some problems with the drugs, which we'll come on to later. So
Yeah.
it is amazing, though, given the numbers. I expect we'll come on to the numbers as well. These are prescribed in their millions and millions. You would think they would be, hugely superior to placebo.
Yeah.
How many there are. It just isn't the case. And it's a testament to the drug companies how well they have marketed a drug that really has very little actual benefit.
Yeah. I actually think that if lay people, like I consider myself somewhat lay people because like I don't have a psychologist training or a medical doctor training or something like that, but this is a topic that has been very interesting to me and intriguing to me. So I've read a lot about this. So I think that if lay people like truly understand what this idea is based on, like what this idea of using these antidepressants is based on, they might be quite surprised if we use some kind of maybe a positive word. Appalled could be a better word, at least for me, because I felt basically betrayed, like when I learned that these are very short-term studies, and what it means that antidepressants work in the study context is basically a drop in the rating scale. And there are many problems with the rating scales. Like, do they actually mean that when the rating scale, what's the word, when these points drop, is it about getting better? Is it about healing? That's one of the things that was very surprising to me. Like personally, afterwards, it's actually after I withdrew from the meds that I started to dig into this more, because one of the surprises that I faced when I learned that it might not be true, that the story that I was told that I should be on the medications for the rest of my life and I would be a psychiatric patient for the rest of my life. And when I started to learn that it may not actually be true, and I withdrew from the SSRI first, actually SNRI, because it was simple that I was using, duloxetine. And I withdrew from that, withdrew myself from that alone, without any instructions back then, because the psychiatrist I was seeing back then didn't recommend withdrawing from me. So I decided to withdraw from one of the medications alone and then going back to him to talk about the rest. But what was surprising to me is that what I started to feel after I tried to do it slowly. I had no idea what slowly would mean, so it was not slow. But anyway, my mood became very unstable, and I was starting to become very anxious, and I was starting to think that perhaps this drug protected me after all from this depression. And perhaps this is a bad thing that I withdrew from it. But luckily, I think you might know this person. It was 2015, spring 2015, that I withdrew from the medication. And Aku Kopakkala, this Finnish psychologist, had just recently published his book about this serotonin myth and about depression and the serotonin myth. And there, in that book, I read a sentence which basically said that like one of the dangers is that when people withdraw from these drugs, they experience withdrawal effects, and those are so easy to interpret as relapse. And as I was reading his book, I realized that I had all these physical symptoms that I hadn't considered. Like my stomach was like totally messed up. I had these tremors. I had like cold and sweating, first like being very like shivering, and then this kind of a sweating, and I had terrible nightmares, like all kinds of weird things that I hadn't considered before. It was just part of this anxious feeling that I had, and that's when I realized that it was the withdrawal that I was experiencing, and that was one of the surprising moments for me. But all the more, I'm not sure. I'm not sure if people can truly get the amount of betrayal people can feel after they experience all this, and then they realize what this research is based on and what this like claim of the effectiveness is based on. Because even if they work, it's not what we usually think about as lay people. that what does it mean when a drug works? Basically, I thought it means that it gets me better, that this depression is going to go away. And I was told that it was because of the chemical imbalance that I had this depression, which is why I stayed in a relationship that wasn't good for me for 7 years. And no one like was interested in asking questions about that. So yeah, there's a lot of surprising things when you start to dig deeper and look at what does it actually mean when a psychiatric drug works. It's not so much about healing. In some cases, perhaps people can experience it that way. I'm not saying that, or they may make changes and like have lessened emotions, and they are able to handle the situation, or in some kind of a crisis situation, they may be like good for them. But it's not about in my view, and at least in my experience in my own life, it wasn't about healing. It was about like lessening the emotions. Yeah.
Well, I'm sorry you went through all that, yeah, and that's and I'm also sorry that's actually quite a common story. I mean, we've now done surveys of people trying to come off antidepressants, and that's very common. What you describe as experiencing the withdrawal effects and then trying to get some help with that and being told that no, these are not withdrawal effects, these are the original problem coming back. And I haven't been through that myself, so I can't imagine the sense of betrayal. I can imagine it, but it must be awful on top of having to deal with the withdrawal symptoms themselves, and you try and get some help, and you realize you've been told some things that aren't true. And that's I don't want to make an excuse for the doctors that do that, but they are just passing on the information that the drug companies have told them. They should be more critical of stuff coming from drug companies, but that's the line that the drug companies have fed them for several decades. Well, there's several lines in there. If I can, I mean, because you talked about the chemical imbalance, so let's deal with that. There is no chemical imbalance underlying depression. That was a drug company myth created decades ago, swallowed wholesale by psychiatry, and repeated to the public and patients for several decades. It's now completely debunked. I mean, there was a very extensive meta-analysis published a couple of years ago by Joanna Moncrief, a psychiatrist in London, and several other people, just showing that there just isn't any evidence for that. And yet, people are still told that today. You go on the websites of the American Psychiatric Association, I'm assuming it's the same in Finland. They're toning it down a little bit here in Britain now, finally. But still, that's a myth that's out there. And even if patients aren't told that, there's sort of an implication, isn't there, that you take some pills, there's something wrong with your brain, something wrong with, and these pills are going to somehow correct that. So there's two falsehoods there. A, that the drugs are treating a chemical imbalance, and B, that they work better than placebo. And then there's the additional lack of information about the side effects and especially the withdrawal. So yeah, I mean, what you describe is very, very, very common, and it's not okay. And we're just beginning to start changing it, at least in the UK. 2 steps forward and 1 step back all the time, but it's beginning to change. But I wanted at some point, maybe now, I don't know, you tell me, Israel, to just talk about the extent of the prescribing that's going on.
Let's do
just briefly
now. Yeah.
Because it is truly astonishing. The prescriptions of antidepressants in every country where it's recorded has increased every year for the last 25 years. Every year, those of us tracking it think this must be the year that it plateaus and begins to come down. But no, every year, including last year, we just see, although the curve in Britain is beginning to slow down, so it's heading towards a plateau. It's curving in the right direction, but it's still increasing. We now have in Britain 1 in 6 people, 1 in 6 adults are on antidepressants. And it's higher in some, but that's not unusual. It's higher in the United States. It's higher in Australia. I don't know Finland. Do you know if what the figures are for
I checked the
It's about the
statistics
same.
that like there's about 5.6 million people in Finland,
Yeah.
and 600,000 people are using SSRIs or antidepressants. Although just yesterday I listened to an interview of a Finnish psychiatrist and the professor of psychiatry who mentioned that some of these antidepressant prescriptions are for pain and sleep.
Yeah, yeah.
Yeah.
Yeah, that's true. That's true. Which is a whole nother
Yeah.
area.
Yeah.
The prescribing of psychiatric drugs for areas for which they were not designed and have not been tested on. That's a whole nother, this off-market,
Yeah.
off-label prescribing. But
Yeah.
before we move on from the number, I just wanted to say this in Britain, and two or three other places where the demographics have been looked at, but I'll just talk about Britain because I know that best. Women are prescribed these drugs twice as often as men. People living in deprived areas are prescribed the drugs statistically more often than people in other areas. And older people are prescribed them more. So where I live here in Newham in East London, which is one of the poorest boroughs in the country, if you're a woman living in Newham, you have about a 50% chance of being on an antidepressant. And that scares me. That's quite terrifying. Apart from the overall this absolute epidemic of overprescribing, the fact that it's prescribed more in deprived areas and more to what are we medicating? The effects of poverty, the effects of a whole bunch of social things that cannot be solved by chemicals, in my view. Yeah. So I just wanted to put it into context, the enormity of the problem, how many people are on them, which in itself is a exemplar of the dominance of this simplistic medical model explanation we have for human distress, which is dominating so much of services when people go for help. So anyway, I just wanted to put it in context. And as I say, you'd think, given those numbers, you'd think these would be about the most effective drug ever invented in the history of medicine and the safest. It is quite bizarre. We will look back on this period in about 20, 30 years' time, and medical historians write about this period and wonder what on earth was going on.
Yeah.
What were they thinking? But at the moment, we're stuck in the middle of it. So.
Yeah. I was just thinking before we started today about the absurdness of the situation I was in, because one of the major steps that I took in my well-being was that an old acquaintance of mine called me. Like I was a psychiatric patient. I had been on wards, like on and off on psychiatric wards many times. I was basically I was considered to be in care, okay, by experts. And a major step forward in my life happened when an old acquaintance called me and told me that he had separated from his girlfriend because their life became so unbearable together that they had like gone separate ways. And I realized that moment during that phone call that that's what I have to find the courage to do, like to leave this relationship. And after I left that relationship, I took a huge step forward. Like it didn't get rid of all my problems. I still had the identity of a psychiatric patient, but the going on and off the ward stopped there. I didn't need to go there anymore because I wasn't so anxious at home anymore because it wasn't such a difficult situation. So how can it be that I was cared for by the experts and a random old acquaintance called me out of nowhere, and that's what helped me move forward, and eventually I'm here. How can it be? Because I was treated, so to speak, by the experts.
Well, we have done some surveys of how often people. No, sorry, not surveys. We've done reviews of the research looking at how often people in mental health services, including psychiatric hospitals, are ever asked about their home situation or their childhood or any of the psychosocial stuff that we know causes depression and anxiety and psychosis. And internationally, the vast majority of people in psychiatric hospitals around the world or in touch with mental health services are never asked, never mind get something to help, are never even asked about the possible causes of the depression. Just assume that there's something wrong with their brains or their genes, or we'll give it a label, and then we'll think we've understood it. You know, well, why is this person depressed? Well, they've got a thing called major depressive disorder, so that's causing them to be depressed, which is as stupid as saying depression is caused by depression. It's like the backward circular logic, which means pretty much nothing, except it instills the idea that it's an illness inside of you, rather than being caused by what's going on around you or what's happening to you, or etc. So yeah, that's a bit of an aside, but I mean that's part of why so many people are on medication, because they're not being asked what's going on in your life and how can we help you with that, which are so, you don't even need research to know that. That's the first thing you ask people. You know, if a friend comes to you and is really upset, what do you get? You say, what happened? What's going on in your life? And how can I help? But no, the services we've designed to help people in distress seem to actively ignore asking those obvious questions. So it still makes me cross. Yeah, sorry, I'm on a rant here. Stop me.
Just yesterday I posted on my Finnish Facebook page related to these mental health topics that what if we didn't call like human distress and life challenges a disorder? Like, how might that change how we try to help the person? And someone commented that we would actually help them solve the actual problem. And I replied to them like, yeah, think about that. Might that be helpful to solve the actual problem instead of medicating?
Yeah.
From my point of view, this would be like laughable if this wouldn't be so tragic, because there's so many risks and long-term things that we have no idea what kind, or at least that's my understanding, that we have many things that we have no idea what can be related to long-term antidepressant use, because there's no like studies about that. It's not something that is very often studied. So it's very easy for people to say, or for doctors even to say, that this is actually mind-boggling to me. How can some doctors say that we don't exactly know how antidepressants work or how SSRIs work, but we do know that these some of the adverse effects that people describe having because of antidepressants, like they can't be caused by SSRIs. So how do we know? How do we know if we don't know exactly how these drugs work? I wonder if this is some kind of a defense mechanism, because it's absurd to me to claim that we don't know how they work, but we do know that these adverse effects that some people claim are caused by them, can be caused by them.
Well, of course, they claimed for decades, didn't they, to know how antidepressants work. This is, you know, the illusion that they're correcting a chemical imbalance.
Yeah.
They didn't really know, because it's not true. But you're right to talk about the short-term nature of the study. So we don't the research tells us very little about the effects, positive or negative, beyond 8 weeks or perhaps 12 weeks. So, I mean, people might not know that to get a drug approved from Drug Administration in America, or the MHRA, Medical Health Regulation Authority here in Britain, you basically you can do as many trials as you like comparing your drug to placebo. They only have to be 8 weeks or 12 weeks, usually 8 weeks. And you just keep going until you can submit two that show some degree of efficacy and some degree of safety after 8 weeks. So you can do 20 that show nothing or show that they're causing all these adverse effects. And you keep going on a random basis. You're going to come up with two eventually, just by chance. And you submit those two and it gets approved. And then you ask, how could that possibly be? And then you look at who's controlling the regulatory authorities, and the FDA in America. Pretty much everybody on the FDA has worked for the drug industry and pharmaceutical companies at some point. It's a revolving door. They go backwards and forwards. In Britain, our mental health regulation authorities is entirely funded by the drug companies. So we don't have an independent scientific authorization process, which is part of the problem. But that's a broader broader issues than antidepressants. But you're right. Going back to antidepressants, you're right. So we don't know much about the long-term effects. I can sort of summarize what we do know. And you referred to it briefly from your own experience about, I think you said you didn't feel, did you say you didn't feel very much of anything, or I was going to talk about emotional numbing as one of the effects.
It was a part of the problem. I had an additional experience, let's say an anecdotal experience that suddenly disappeared after I withdrew from the meds. Well, for example, my emotional range was definitely limited, and actually I also think that my ability to empathize for other people was also severely limited, because I didn't care so much. That was one of the things that I've been thinking about afterwards. Like, it's scary to think that I'm a very caring person, and for years that was something that wasn't very apparent to me, or to basically to anyone else, I guess. It wasn't this. I didn't feel connected even to my emotions, and even less to anyone else's, if that makes sense. So that's one of the things that is very worrying for me, like considering all these this amount of people who are using these drugs, how many perhaps could feel this way. And also the other thing I was going to mention, I had sometimes these weird experiences of being out of my body, these very weird experiences, and I thought to myself, like, I must be very crazy because I'm having these kind of experiences. And I was also using antipsychotics and Lamictal, this kind of I think it's an epilepsy drug, but it's used for mood stabilizing effects, so to speak. But I also had those drugs. I never mentioned anyone about these weird experiences of being like dissociated from my body and looking at myself in certain situations as if I were like outside of my body. They were very disturbing experiences, but I didn't mention these to anyone. And afterwards, I started to think that I was very surprised, because I thought that was just part of who I am. It's something that a person like me experiences, whatever that means. After I withdrew from the Cymbalta, those experiences disappeared. I've never experienced that again. So I started to think, I still had the other two drugs, because that was the first one that I withdrew from, that Cymbalta, but they've never came back. They've never came back. So it really got me thinking, like, oh my goodness, like, how might this be for some people with experiences like this, if they were caused by that drug, they can be a trap to more, like to this polypharmacy. And even the one of the ways I think people end up in with multiple psychiatric medications is because, even though there can be a sort of let's say a honeymoon phase with a SSRI, for example, because it numbs the emotions, it can feel like this is helping, or I feel different, this must be helping. In the long term, it might end up like, okay, this didn't actually solve the problems, or I feel nothing. I don't feel connected to myself, or to my feelings, or to other people. There seems to be more problems, and the situation might worsen over time. And it's not very easy to see that path from the first drug to the worsening of the situation and ending up to multiple drugs. I didn't notice it. I do now, looking back, but I didn't notice that like that shift going on.
When we have conducted surveys of hundreds of people, usually about 1,000, we've done several. The sorts of things you're describing there are very common. So I'm not going to dig out the exact percentage, but more than half of people describe emotional numbing, which is, is a narrowing of the range of feelings, or feeling nothing at all. So people will say things like, yeah, I don't feel depressed, but I don't feel anything. I don't feel any joy. I don't feel any fear. And they also talk, more than half talk about caring, like exactly what you said, caring less about other people. They just don't feel connected to themselves, to their feelings, or other people. So they're sort of living in this void, if you like, this empty void, which maybe for some people temporarily is better than means really, really, really depressed and suicidal. Maybe it's like they've just been switched off. That's a very crude way to summarize it. But when you think about it, those sorts of things are really actually quite depressing, not to have access to your own feelings and to be not connected to other people, which, if we're honest, is our major source of feeling good and safe in this world, is our relationships with our special other people, whoever they may be. So that's turned off. And then one of the more recent things that's been oh yes, so people also talked a lot about not the major term there is not feeling like myself. I just don't recognize myself. It's not me. But another thing that's come out more recently is how common the sexual dysfunction is, which is very, only I would say the last 5 years of, or maybe other people have paid attention to it and I haven't, but in the research it just seems to be a lot being talked about now. And that's another source, intimacy, and another source of feeling good. So we're actually doing things. These drugs are doing things that make people feel. I don't know if they feel more depressed because they can't actually feel anything, but they are depressing things, not being connected to other people or not being able to be sexual, and that's before we even talk about the fact that these drugs increase suicidality for a significant number of people, usually only for the first few weeks. So if you get through those first few weeks and the suicidality, you're okay on that front. But how bizarre that a drug that is supposed to alleviate depression causes increased suicidality in a significant number of people. And it's not just young people. We used to, the first few years this came out, we thought it was just the 16 to 25 years. It's not. It's across the board. That is truly bizarre. Why is a drug that, I don't know, it sounds simplistic, that a cancer drug that is shown to increase cancer, how long would that stay on the market? So yeah, I'm on another rant here, but the list of adverse effects, once you get past those 8-week studies and look at, because our surveys of course include people in the real world who have been on them for months or years or whatever. It's not a randomized sample, so it's not perfect science by any means, but these are the largest surveys that have ever been conducted, and there are people in the real world, and sometimes, like your situation, looking back and understanding more from a perspective of having sort of come out the other end, some of them, they can see it sometimes more clearly what they went through. So yeah, it's very, very worrying adverse effects profile. And people are not told about those effects. We also, that's not just an opinion, that we've researched that as well. We haven't even come on to withdrawal yet, but we know people are certainly not told about that, but they're not rarely told about, a little bit. Some people are told about the suicidality for the first few weeks, but a lot of the other effects, emotional blunting, and so people are not really told about. So, and that's, it's safe to say that's unethical because that's breaking the important principle of informed consent. So, so there's several topics. There's the adverse effects, and then there's the informed. So I'll stop from it. I'm trying too much information out there.
Yeah, I'd just like to mention that we talked about how often these are used, how many people use these drugs. So even if there are some quite rare side effects or adverse effects, I think we have a lot of people who might be experiencing them without understanding that they are related to these drugs, because it's so common to use these that even these so-called rare adverse effects might include more people than we like to think. And
they're not rare, Pia. None of the ones I listed. There are some others that are quite rare. But
I was talking about the more rare ones, but I just wanted to say that even the rare ones are issue for us because so many people are using these drugs.
Yeah.
So that's what I wanted to to bring forward, this idea that even the rare effects are quite common when looking at the global population, because the amount of people using these drugs is so huge. And I think one of the things that I've been listening to people's experiences about and reading about is PSSD. So would you perhaps say something about that?
Well, that's just the sexual dysfunction, isn't it? And sadly, we don't know enough about it. I don't think we've got a very good estimate yet of how common it is. It's common, but we really don't know how much. And we also don't know for sure how long it lasts. I mean, some people are describing it as a direct effect of the drugs. Some people are sort of seeing it more as a withdrawal effect. It comes out for some people only when they're going through the withdrawal process, which we haven't come on to withdrawal yet, but we will. And then there's the question of, is it permanent, which is a question for a lot of these adverse effects, because we literally don't know, because we haven't done, that takes studies lasting 5-10 years to know whether something is permanent. So we don't know, these are things you should know before a drug is prescribed, not have to start discovering it 30-40 years after the drugs have been on the market. So but yes, it's a very serious sort of, I mean, at its, there's many forms to it, but at its simplest, it's a numbness of the genitalia. So people just aren't able to experience any sexual arousal. And I guess maybe one of the reasons it seems to be one of the last effects we're discovering is because it's embarrassing to talk about. It's not, I mean, none of the things are easy to talk about, but that's quite a difficult thing to talk about, to tell your doctor about, or to tell your friends or whoever you usually get your support from. But yeah, we're discovering not too late, but later than we should. The institute that I'm chair of, that you mentioned, Institute of Psychiatric Drug Withdrawal, is doing a seminar on this next month. If people want to go to the website, we can put that out, maybe the institute's website, where we've got some of the leading speakers, including David Healy, and one or two of the members of the organisations that have been, the self-help groups on Facebook and so forth, that have been promoting awareness. So we're bringing sort of experts and service users together to put on a webinar about it next month. But yeah, it's very, very important, very, very worrying, and people are certainly not told about that when they're offered antidepressants.
Yeah. To get back to one of the topics we talked about a bit earlier, you mentioned the Moncrief, this umbrella review from a couple of years ago. Like when I mentioned about that some doctors say that we don't know exactly how these drug work. It was interesting to listen and read what these mainstream psychiatrists were like, how they were handling that review, because that's one of the things that came up, like we've never said that. It's this simple serotonin imbalance, like no one's ever considered that, like, and weird explanations and like these turnovers, and that's what I refer to, like we don't know exactly how these work, but like it can't cause things like that, which I find a bit unbelievable, considering that if I'm not mistaken, serotonin is basically a whole body chemical. So how do we know that we're not messing up many more systems than they would like to think?
Yes, well, one of the gaps in the research is what are the actual effects of artificially introducing blockades or enhancers to various neurochemicals. We have the same issue in psychosis. The whole issue of dopamine there. When you block the dopamine system with antipsychotic drugs, the neurons start producing more dopamine. So that's for another time. But yeah, when you artificially cause, and because the drugs are, they are having a chemical effect, they're causing brain abnormalities because they're being they are impacting a normal brain that has nothing wrong with it. And of course, they do have effects on the brain, on the neurotransmitters. And that's Joanna Moncrief, the psychiatrist we keep referring to, talks about the disease model of drugs, which is the traditional one, which imagines that the drugs are correcting some imagined imbalance, and the drug focused approach, which actually talks about what the drugs actually do. Forget the disorders, and just look at what the drugs actually do. And to be fair, we don't really know. We certainly don't know long term. We don't know the effects of these drugs being prescribed to adolescents and children, which we haven't talked about, which is massively on the increase, especially in America, but also here in Britain. We're talking 5 to 10-year-olds now being put on antidepressants, which is, that terrifies me. We have no idea what that does to the developing brain, but they just do it anyway. So yeah, we don't know. But you talked about the reaction to Joanna Moncrief's umbrella review of that. It was hysterical, actually. I mean, so there are quite a few laugh or cry moments, aren't there, Pierre, in this saga. And sometimes you have to laugh. But about a third of the responses, very crudely, were, "We never said that.
Yeah.
What are you talking about?" And on that same day, they said that you can go to the website of the American Psychiatric Association or any joint. They're still saying it. Another third came up with this great idea. Well, the only people who have ever said that are people like Joanna Moncrief and John Reed and all those anti-psychiatry people. They've made it up to make us look bad. And the other third were saying, it's true. How dare you say there isn't a chemical imbalance underlying depression? It's like, it was really quite, and Joanna had to she wrote a rather erudite response to all of these bizarre defensive response. I suppose it's understandable they're defensive. If you've believed something for a long time and publicly espouse it and it's shown not to be true, you're not going to go, "Oh, thank you for pointing that out." You're going to go into defense mode, aren't you? But anyway, yes, it's just the reactions to some, pointing out what the research actually says is always kind of interesting. But I do think we should talk about withdrawal for a bit before we run out of time, as we always do. Time flies so quickly when we're talking. So for decades, the word given by drug companies to psychiatrists and GPs and passed on to patients was that there is no withdrawal effect for antidepressant. There's a thing they call discontinuation syndrome, which was a term invented in 1997 at a drug company conference in America, where we've got records of this meeting. We must not call it withdrawal effects because we must distinguish it from benzodiazepines and the opiates. And so we'll call it, if we must talk about it at all, try not to talk about it. But if you do, call it discontinuation syndrome. And then they put out a statement. It was a little vote. There's about 8 of them. They voted as to, or discussed how long should we say it lasts, and they decided it's 2 to 4 weeks. No studies. They just decided this is the word we will put out to 2 to 4 weeks, and it's mild, so nobody needs to worry anything about it. And you can read exactly those words for decades on the websites of the British Royal College of Psychiatrists, the American Psychiatric Association. Just reproduce this garbage from the drug companies. Anyway, to cut a long story short, we now know from James Davis and Roehampton published a review in 2019, which had turned out to be quite an important review, more important than we realized at the time. There were only 14 studies at that time, and we estimated, looking at all of those studies, that 56% of people, on average, will experience withdrawal effects when they try to withdraw or even just reduce antidepressants. And of those, an average of 46% describe those effects as severe when given the option mild, moderate, or severe. And many of the studies talked about people taking weeks, months, or sometimes years trying to come off the drugs and not being able to, or succeeding in the end, but taking many. And there was then something of a campaign from some of us to try and get this into the public domain. It involved taking out a complaint against the Royal College of Psychiatrists, whose chairperson was insisting publicly that it's only 2 to 4 weeks, etc., etc. But Public Health England did a big review on it, which was very, very helpful in 2019. Anyway, to be fair, the Royal College of Psychiatrists did a complete U-turn, and it's back in 2022. Their website changed completely, and they talk accurately now about long-lasting severe withdrawal effects and how people need to come off slowly and carefully. And nice guidelines here, which is our National Institute of Clinical and Health Excellence, which is our official guidelines for. They changed their guidance as well, so we made some real progress. But we still haven't got that information through to enough GPs yet, and nor do we have. The most important next step is getting dedicated services for people who are trying to come off. In the UK, we have only one clinic in the whole of the country that is established to help people come off psychiatric drugs, and that's staffed by 1.5 people. And I know in many countries there isn't any dedicated services. People are supporting one another on Facebook groups, thousands and thousands of people on multiple Facebook groups, helping one another do what professionals ought to be doing. But because of their ignorance, they're not, because they've swallowed the drug company line. So we go back to that situation you described at the beginning here, where so many people are trying to tell their doctors about withdrawal effects and get some support to come off gradually and slowly and carefully, and being told, no, this is evidence that you need to stay on them. In fact, we probably need to increase the dose because clearly your depression or your anxiety is coming back. That's what you're describing. So we've got a long ways to go yet, but at least we've established the fact that it exists, that it's common and it's very often severe and long lasting. We've had the same backlash to that. So there have been 2 or 3 very, very badly done reviews trying to establish that our review was exaggerated. And there have been reviews which have only looked at studies lasting 8 weeks and said, well, there's not very much withdrawal after all. What were they talking about? Mm-hmm. And they get published somehow. Bizarre. So while we're on this, I have to stress two things in case I forget. Number one, and I know you'll agree with this, Peter, because we've said this to listeners before, nobody should make any decisions about withdrawing or reducing their medication on the basis of listening to one podcast. You may go off and get some more information or do some more reading or talk to a prescriber, by all means, but do not change anything on the basis of listening to one podcast. And also, if and when you do decide to try to come off, quickly some golden rules, if I may, which are research-based. For most people, you've got a better chance of coming off if you do it very slowly. Not everybody. Some people, we're all different. Some people manage to somehow just throw them away and they're fine, or come off very quickly in 2 or 3 weeks. Most people, you need weeks, months, sometimes years. You need to do it in an individualized way. Don't let anybody tell you there's a magic formula, like come off 10, 10, 10, 10, or cut it in half a week and then stop, or anything like that. It has to be individualized at your own pace. So it's trial and error. Try a little reduction, see how that goes. If the withdrawal effects subside after a while, then try another little reduction. But be prepared to go back up again, because your life is still going on. There's stressful events still going on. And that's not a failure. Most people do it like this, sort of slowly coming down. I'm sort of my zigzags and do it like that, mm-hmm. rather than like that. And the other piece of information that Mark Horowitz and other people have established in the very important Maudsley deprescribing guidelines, which is out there now since last year, is that you need to reduce by a percentage of the previous dosage. So each reduction is smaller than the last. And that's particularly important right at the end. And the mistake that a lot of people make is they get close to the end, they throw I'm nearly there, and they throw it away. And that's when you need to reduce by just smaller and smaller doses right at the end. So just some general guidance. There's lots of information around that sort of stuff out on our website, for instance, at the Institute, or in the book I mentioned, the more deprescribing guidelines. Or there's quite a lot online now about that last bit. The technical term for it is called hyperbolic tapering, where you're doing, using the percentages, and that sometimes involves trying to get it into liquid form or whatever. Otherwise, some people end up cutting the pills and counting granules, and gets quite tricky. So I just thought it's important to get some of that basic information out there, because you sometimes don't get that from the doctors, because they don't know. They don't know yet. We're trying to get that information out gradually.
There's something that I'd like to suggest to people. If they decide to come off, and please prepare for the withdrawal plan like properly. And one additional tip that I'd like to give is that when you withdraw from these meds and your emotions come back, I think it's a good idea to talk with your loved ones, with your family members, with your friends, and tell them what's going on. That you're withdrawing from these medications, because they can get scared when emotions come up again. That's one of the things that luckily my husband was very calm when my emotions started to come up again, and practically he never knew what was waiting for him when he came back home from work. Mostly a crying wife because of whatever I had just seen. For example, cute ducklings walking on a video I had just recently watched, and I was crying my eyes out because it was just too much to handle. These cute yellow ducklings, like what on earth? And then one of the funniest moments is I had watched a video. If you'd like to go to watch that video that got me like really crying my eyes out, it's you can find it on YouTube by searching silent owl flight. I think that's what you find it. The owl was flying in front of a microphone, and there was no like spikes or anything in the audio. So that got me crying. So I just want to say very clearly, please prepare your loved ones also to tell them about, like, I might get very emotional. I might get more emotional than you're used to, especially if you're feeling the numbing effects very much. So that I think that's also helps to prepare for so that they don't get scared. And
very good advice. Very good advice. Yes.
Yeah. One additional point to what you mentioned before about the discontinuation syndrome. One of the things that I felt betrayed about was the amount of marketing and positioning and branding that is included in these, how these psychiatric medications are positioned and how they are talked. That was one of the things that was very disappointing to me, that it wasn't as scientific as I had thought. It was more about marketing and sales and branding, and this positioning, like we have to differentiate us from the benzodiazepine, so we have to call it something different than addiction or dependence or anything. So discontinuation syndrome, it is.
Yeah, I clearly the drug companies are to blame in many ways, but at the same time, they're just doing their job. Their job is to maximize profit for their shareholders. And like any company trying to sell something, their advertisements are not true. I mean, we don't really believe that detergent washes things whiter than white, do we? And we accept, that's a company talking rubbish to sell us things. And unfortunately, they do that in the medical world as well. So my frustration really is not so much with them, although it would be nice if they were a little bit more ethical, but my frustration is with the profession, psychiatry, which has forgotten what a proper boundary is between a medical scientific discipline and a profit-oriented industry. Of course, you have to interact, but you have to have a boundary and some standards, and you have to be scientific and ethical and not just reproduce whatever the drug company tell you, but follow the money. The drug companies have thrown so much money at the professional organizations and at the research journals, which all carry drug company advertisements. In America, this whole schools of neuropsychopharmacology are owned by the drug companies, not just appointing one professor in there, they own some of the schools. Most of the postgraduate education in America, after doctors qualify, is paid for and run by drug companies. They've lost a boundary between themselves and the profit-oriented industry. That's what they've got to re-establish before they're going to regain the trust of the public, I believe. And there are many psychiatrists within psychiatry trying to do that, and are very frustrated with their professional organizations who are not taking a proper stand in relation to the drug companies because of all the money that they benefit. I know it's simplistic, but most areas, if you want to know what's going on, you say follow the money, don't you? And I'm afraid that's true in this field as well. Much as we like to think we're operating in an evidence-based world, I'm afraid psychiatry is not.
Yeah.
Bit preachy, sorry.
I think we're up to our time for this episode, and our next episode will be in a few months. I think in May, perhaps.
Yeah.
And our topic will be antipsychotics. So we'll continue in this series, and we still have at least psychosis and I think alternatives in our plan for the future as well. And I'd like to say to our viewers that if you enjoy these episodes, even though these are challenging topics, and you think that these topics should be discussed more, please share this episode with your friends and let people know that we are doing this kind of challenging the medical model of mental health. I think this is such an essential topic for us to discuss and for people to really get to understand the problems we have when we are using this current paradigm and why we need a paradigm shift in mental health. Yeah. Any last words you'd like to say?
Well, yes, just to remind people not to stop taking their medication or reduce it because of this podcast, to acknowledge that some people find these drugs helpful. And again, to remind, if you are going to come off, do it very slowly and carefully in your own way and very slowly right at the end. And just to thank you, Pia, for setting all this up. I really enjoyed talking with you. I think it's really important that people like us have these discussions. So thank you so much for asking me and organizing all this. Appreciate it.
And thank you. I appreciate your time, spending here your time with me to discuss these topics. And now let's call it a day.
Bye, everyone.
For today. Bye bye.